Without further ado, you guys, let's go ahead and get started. Welcome to, I think this is the 19th installation. We're getting close to 20 of the West Coast Fellows Conference. Very excited to have a good friend of mine here today, Peter Derman. So Peter and I actually met at Rush when we were fellows, he on the orthopedic side and me on the neuro side. Super nice guy, great pedigree. I think he went to Stanford undergrad and then went to Penn for medical school and got his MBA from Wharton. Did his residency at HSS before his fellowship at Rush. And the cool thing about seeing Peter's trajectory is that we weren't exposed to a ton of endoscopy when we were fellows. And it's something that he's learned as an attending and really, I think is probably the thing that he's best known for. And so for the fellows on the call, that's just something that's important to keep in mind. Your learning doesn't stop when your training ends, and you may become an expert in something that you're not even really exposed to a whole lot as a fellow. So it's been really awesome to see Peter's trajectory and super excited to have him talk about endoscopic surgery with us today. And before I turn the screen over, I do just want to plug our upcoming Bridging the Gap conference. It's July 21st, 22nd. It's in beautiful Southern California. Serena is our keynote speaker, and registration is free for residents and fellows. So please register if you can make it. It's going to be a great meeting. It's a little bit different. It's not a ton of abstracts and sort of formal meeting. It's really focused on gaps that need to be filled in spine surgery. And if you are interested, just message or you can reply to the invitation to the West Coast meeting. And there are also some funding opportunities available through the SDSF in sort of collaboration with that meeting. So if you're interested in the funding for research that you're doing, if you're interested in the meeting, please just respond to us. And without further ado, I'm going to turn it over to Peter. So Peter, I'm going to stop sharing my screen. And you can start sharing yours.
For sure. Thanks, Hanny. So, give me 1 second. How's that working? Can you see everything? My intro slide here?
Yeah, you're up.
All right, cool. Well, welcome everyone. Thanks for tuning in. Today, I'd like to give you really a brief overview to get you excited about endoscopic spine surgery. This is certainly by no means comprehensive, but I did want to show you the power of what this can do for your patients and for your practice. So we'll do an overview and go through some cases as time permits. Let's see. Here we go. Here are my disclosures. I do consult for and teach for Joymax, which is an endoscopic company, but that's only because I feel passionate about it. So I think the first question to ask, especially for fellows coming out, is why should I bother to learn this? As Hanny mentioned, I never saw endoscopy in my training and had to learn it separately as an attending, which takes some effort, it takes some time, and it takes some dedication to doing so. So why should you bother doing something that you don't necessarily feel comfortable doing? There's a bunch of reasons. So the first reason is and the most important reason is it's good for your patients. And it's not about tiny incisions. I know that's the social media version of endoscopy, but really minimally invasive in general is about preserving the soft tissues and the underlying tissues. And with the endoscope, it's just so small that you have almost no soft tissue morbidity. And as a result, you have very happy patients. They go home within a few hours of surgery. You're not prescribing narcotics. You're certainly not refilling narcotics. And as a result of that, you're a happy surgeon. This is kind of neat. This is a patient of mine who had a right paracentral disc herniation at L5S1. I did an interlaminar endoscopic discectomy, and then she got a subsequent lumbar MRI a year or two later for unrelated reasons, which was pretty cool. It allowed me to check my work. And what you can see is I was very, able to decompress her nerve. There's no disc herniation there. And the real cool thing is, if you look at the paraspinal musculature, you can't even tell that I was there. And that's really the key to having these patients bounce back so quickly and be at work the next day after spine surgery. Interest is growing. So I've been doing this for about 4 years. And when I first started doing this, even my minimally invasive mentors were a little bit skeptical about this. They were like, is this, sham surgery that you're learning how to do? It was not kind of well received necessarily in the mainstream for a number of reasons, but that's really changing. And I think that, the wave is cresting. If you just put endoscopic spine surgery into PubMed, you can see that the number of publications is really skyrocketing skyrocketing. And I think that is a barometer of kind of just general interest. Here's another thing. As a fellow or a young attending, you've got the time. So that's one advantage that you have when you're building your practice that kind of the gray-haired, more established surgeons don't have, is you have the time to, one, spend time with your patients, and two, spend time learning these new things. What the learning curve literature shows for endoscopic spine surgery, both in the lumbar spine, this is not my paper, but one that I published with Christoph Hofstetter recently in the cervical spine, is that the learning curve is all about operative time and not about effectiveness or safety. And for me, learning something outside of a training environment on actual patients, that was very important from an ethical perspective. So I knew that while I was maybe a little bit slower, I was still able to safely and effectively complete these surgeries, which was really important. And that time that you have as a new graduate building your practice, because you don't have a bunch of cases to get through in a day, is really an advantage. In this study, you could see that their first case took almost 300 minutes. But then rapidly they got a lot faster. And that's consistent with what my early learning curve was as well. And then finally, this skill allows you to really differentiate yourself. You know, I came out in a very saturated market where everyone claims they're a minimally invasive spine surgeon, even though I felt like, you know, I was doing a lot of more cutting edge stuff than most. But anyone can say they do minimally invasive spine surgery. You can't just say you're doing endoscopic surgery unless you are, or I guess you could, but that would just be lying. Albert Telfian and some others in Europe, Telfian's at Brown, put out a very interesting study just looking at how far the average patient traveled for their endoscopic spine surgery. And, you know, in the United States, the distance was 91 miles average for surgery, you know, traveling past many, many other spine surgeons to get to this person that can do the endoscope. And, you know, in 20 minutes, I'm going downstairs to do a 2-level endoscopic cervical foraminotomy on a guy who flew here from Colorado yesterday. Next week, I'm doing a woman from Australia. So, you know, they're flying by hundreds or more spine surgeons to come to us for this kind of differentiated treatment that we can offer. All right, let's go over a little bit of the nitty-gritty of how you do endoscopic spine surgery and what it is. For the lumbar spine, which is really where I would recommend starting, there's two major approaches. So there's the interlaminar approach and there's the transforaminal approach. And you don't really learn this in standard spine training unless you're doing endoscopy. But basically, the overall goal is to minimize bone resection for a couple reasons. One, why take away bone if you don't have to and potentially sacrifice stability? And then two, taking away bone is kind of slow. And so if you can utilize and exploit an existing bony opening, you can get the case done a lot more efficiently. So just to, at a high level, and there is some variability surgeon to surgeon in this, any foraminal or far lateral pathology is going to be a transforaminal approach, an outside-in approach. In the canal, if you're doing soft discs, which is where you should start, at L5-S1, you usually go interlaminar. And the reason for that is the interlaminar window is really big. So usually I don't take any bone at all when I'm, you know, doing an interlaminar discectomy. And at L5-S1, the pelvis is in the way. So it's hard to go transforaminal and get all the way into the canal. However, that balance shifts as you go cranially. So at L4-5 and above, usually the interlaminar window is smaller. And so you do have to remove some bone in order to get into the canal. However, the pelvis is not in the way. So the crests don't block your entry. And so you can get all the way to the mid-canal and beyond from a transforaminal approach. So at 4-5 and above for soft pathology, I'm doing almost always a transforaminal approach. And then for stenosis cases, you know, it's dorsal compression. So you're usually going to go interlaminar for that. And when I say stenosis, I mean canal stenosis. So let's briefly go through each of these approaches just to give you an idea of what this looks like. And this is a case that I did pretty early in my practice of endoscopy. You see massive disc. There's no limit to the size of the disc that you can get out. And this is kind of the post-operative healed incision, which is pretty incredible. So access. So interlaminar, first you're going to dock. It's almost like docking a tubular retractor, very similar. Then you put a working cannula down. It's 8 millimeters to give you an idea of size. And this is going to be a right-sided L5-S1 discectomy. And the the landmark that you're looking for is the trailing edge of the lamina. So this is the right-sided L5 lamina. Cranial is over here, caudal's down here, the spinous process would be up here, and the facet joint is down below. And then the interlaminar window is just caudal, obviously, to the trailing edge of the lamina. So I clean that off just to give me an idea of where I am. And then the next thing that you do, let's see, the next thing that you do is you make, if you need to, a little hemilaminotomy. And there's a variety of different burrs. This is a diamond burr. It's a good starting burr because it's not very aggressive. It's very safe. And when you're first starting out and you're not comfortable, it's a good one to start with. So you make a little hemilaminotomy if you need to, just big enough to get the endoscope in. And this is what that looks like when you're done. Here's your little hemilaminotomy, just like you would do if you were doing this through a tubular retractor or through open means. And below that is your ligamentum flavum. Then the cool thing here is there's this little instrument, which I call a micropunch or a scissor, which is blunt at the tip and only cuts to like a millimeter shy of the tip. And so what you do is you thin the ligamentum flavum and then gently poke through with that blunt tip, which allows the fluid pressure to rush in and really acts as a retractor and pushes away the dura. And so a lot of people worry, oh my goodness, uniportal endoscopy, I only have one hand, but really in many ways you have two hands. One is using your instruments and the other is retracting, one with the fluid pressure and two with the cannula itself, which has a bevel on it. So the next thing you do is you take a kerrison, and that's about the equivalent of a 3 kerrison, and you remove just enough ligament coming toward yourself to allow entryway into the canal. You don't have to take down much ligament, and really just the width of that 3 millimeter kerrison is enough. Then what you see is the epidural fat, and it's just the visualization is so well preserved that you see all kinds of stuff that you wouldn't otherwise see. But you remove that epidural fat and this little, filmy, wispy membrane over it. And what you see is a very nice view of the traversing nerve root. So in this case, it would be the right-sided S1 nerve root with the disc herniation below it. You can see that root is really tensed over it. And so then this is like a little Penfield. I just free things up, and then you can do your discectomy. And the move is to kind of grab and rotate, which allows you to remove disc in kind of larger pieces. And so I'll kind of skip through this, but you get the point. So once you do a preliminary discectomy and kind of loosen up the nerve a little bit, then the move is to retract that nerve out of the way. And what you do is you rotate. You'll see me starting to do this here. So the tine is lateral here. And the bevel is medial, and I rotate to mobilize that traversing root, and ultimately I can rotate the tube 180 degrees. And once I've done that, you can see it right there, I'm completely circumferentially protected in the lateral recess. There are no neural elements there, and I can very safely complete my discectomy. And this is just a diagram showing that move. So you start off with the bevel medial, then you rotate 180 degrees, and you have unfettered access to the disc herniation. When you're done, you can trace that nerve up and down, you get hemostasis, and you close, which is a very quick closure. A question I often get is, how do you know when you're done? And there's a variety of things that you can do. I take x-rays, I manipulate the nerve. You can see that it's a lot easier. I save the disc and I take a picture of it and make sure it's the same size as what I would expect based on the preoperative MRI. And then you can just see so well. So this is a shameless thing that I named after myself because who else is going to? The Derman shadow. So this is before I do a discectomy in a case, so very similar case. And you can see the nerve really tensed over this disc herniation. And then when I'm done, you can see that shadow underneath the nerve. And really beautifully, you can tell like this thing is decompressed. And the reason you can tell so well is that the optics of the scope they're off-angled optics, so you can see around corners. So you can really see underneath that nerve and see that, heck, nothing is pushing on that nerve anymore. So that's interlaminar. Then there's also transforaminal. Transforaminal is a great technique for all kinds of different things, but not just foraminal and far lateral pathology, really getting to the canal. This is a patient who had a previous kind of traditional left-sided microdiscectomy who then reherniated at some point. And I'm able to go transforaminal, avoid and totally bypass that previous scar plane, and you can very nicely do a revision discectomy, which once you get over the learning curve is a much easier way of doing this. So just to give you an idea how this works, transforaminal, there's a guide wire that you put down. You want to dock on the back of the bone. And then you make an incision. There's some sequential dilators that go down. There's some sequential reamers that go down. You do this under fluoroscopy just to open up the area in that foramen. But importantly, what you're removing is the non-articular undersurface, or shaving down the non-articular undersurface of that SAP. You're not removing facet joint. And there's a really nice biomechanics study showing that you can really increase the dimensions of that foramen much bigger than if you do kind of a traditional posterior inside out foraminotomy without destabilizing the facet joints. So very powerful, not just for soft pathology, but for foraminal stenosis. There's a working channel that goes down, your camera goes in. This is the view that you see. So this is a 3-4 on the left. So this is caudal. So this would be the 4 pedicle, and it arches up into the SAP. That's really your bony landmark. And then the disc and the traversing nerve root. And then depending on where you need to go and what you need to address, that's what you do next. So just to give you an idea, this is that arch. So this is the reamed undersurface of the SAP. And as I work my way cranial, you can see all this fat in vessels. That's the epidural fat around the exiting nerve root there. And this is an example. So if you're trying to get into the canal, initially all you see is disc for, if it's a paracentral disc herniation, and you just very, meticulously undermine that disc herniation, remove it piece by piece, and the nerve floats into view. And then once you see the nerve, you can be a lot more confident, work underneath it, and remove everything from underneath that nerve. And this is what it looks like when you're done. And if it's a central disc herniation, you can advance your endoscope all the way into the ventral epidural space. I always like to take this x-ray with the ball tip probe as far as I can see. And in this case, I could see all the way to the midline and be sure that I was done with my decompression. The other cool thing is you can turn your scope around 180 degrees because of the angled nature of the optics and look back towards yourself, which is kind of an out-of-body experience, but allows you really to nicely access far lateral pathology. And so this is what it looks like in your scope. So I'm rotating all the way around. That was my arch. This is my exiting nerve root. And then looking back toward myself, this is the hypotenuse of Camden's triangle. And so out here would be the far lateral region, and you can see the shadow there because it's decompressed. But before you start, there's a disc herniation here, you can easily access that. As far as advice to people who are thinking of adopting endoscopy, I would say start with easy cases, which is really soft pathology in readily accessible areas. So for the transforaminal approach, as I alluded to, that's in the foramen at L4-5 and above. For the interlaminar approach, that's paracentral at L5-S1. And then you just gradually do harder stuff. So L5-S1 transforaminals, migrated discs, stenosis cases, cervical thoracic cases, and fusion type cases. Now, I have a series of cases that I had prepared, but actually in the interest of time, I'm going to skip ahead because I want to show you the final case. All these cases were lumbar, and there are interesting ways that you could use endoscopy, not just in order to make the morbidity lower, but in many cases in order to help patients avoid fusion. And so, cases where patients either had a deformity that if you did a traditional decompression, you would have had to fuse them, et cetera. So if we have time, we can go back to those. But I also wanted to show you a cervical case. This is not what you should do as your first few cases. And I did not start doing endoscopy because I was enticed by cervical, but has become really one of my favorite uses of endoscopy, and is really a wonderful procedure. So posterior cervical endoscopic foraminotomy, it's almost like a stealth surgery. You get in there, you can remove stenosis, you can remove disc herniations, and patients have almost no pain. It's really incredible. So just to give you an example, this is a 48-year-old guy who came to me with an acute left C8 radiculopathy, including weakness. And you can see he has a left-sided disc herniation at C7T1, which corresponds with his symptoms. So, traditionally, this is a hard case. And this was referred to me by one of my partners because difficult to get to from the front. If you can get there and see, ACDF is an option. Disc replacement is not approved at C7T1. So you're kind of stuck at this level. It's a difficult conundrum unless you know how to do a foraminotomy, and especially an endoscopic foraminotomy, which allows patients to bounce back so quickly. So just to kind of walk you through this, similar to lumbar spine, you dock a tubular retractor. Basically, it's the same 8mm retractor. And then the steps are the same as if you were doing this open or through a metrics or tubular retractor, but the visualization is so good. So this is the interlaminar V. Just to get you oriented, this is the left side, and we're looking at C7T1. So this is the C7 lamina, T1 lamina coming together in a V. The ligamentum flavum would be underneath here, and then the facet joint starts here. That's your bony landmark to start off with. Then you can use that diamond burr, and this is what I'm going to be doing in 6 minutes from now, to remove first a little bit of that C7 IAP, which I've done here, and you can use a kerrison as well, to expose the SAP below of T1. And you really want to take it down, just as you would in any foraminotomy, to the top of the T1 SAP, because you don't want to leave any of that bone in there, which could cause residual stenosis. So you can see I burred and kerrison down the IAP all the way to the tip of the SAP, not taking too much lateral. You want to preserve 50% at least of the facet joint. Then you kind of nibble that away, and underneath it, lo and behold, it's a beautiful picture. So this is the left-sided C8 nerve root, and underneath it, you can see that disc herniation there. And, when you do these open or any other way, there's that venous plexus that, it bleeds. It really makes visualization difficult. But I find that it's actually much easier with the endoscope because the hydrostatic pressure of the fluid tamponades that venous plexus. So you get these really beautiful views, and you can see if there's a soft disc, you can very safely, under direct visualization, reach underneath and remove a disc herniation. And then when you're done, you can kind of manipulate that nerve up and down and confirm to yourself that you are indeed done with the decompression. You want to go pedicle to pedicle. And when I used to do these through a tube, you kind of feel with the probe and try to convince yourself that you're, to the lateral aspect of the pedicle. But again, the nice thing about the endoscope is it's off-angled access lens. You can turn around and actually see the lateral border of the pedicle, look out the foramen, and convince yourself that you're done. So you get these beautiful views. And this is that view out the foramen looking laterally. This is the one pedicle and this is the other pedicle. And you're just very confident that you're done with your decompression. And this is kind of the post-operative course. I was all the way up at the pedicle above and the pedicle below and out the foramen. This is the disc that came out. And, he actually brought his wife to see me like a year or two later. So I got to, see his incision down the line, and he continues to do great. And, just really proud that I was able to help him in this manner. A couple of cases in which I was able to check my work where people got imaging for unrelated reasons. And you can see that you can very nicely do exactly what you set out to do. So these are two different cases, but you can see I did a right-sided foraminotomy here, decompressed adequately, but preserved enough of the facet joint, and the same thing on this side here. So, very cool cases. I think you can probably see I'm very excited about this. I'm generally excitable. It is certainly a learning curve, but I think as a young attending, this is the time to learn how to do this. And I do not think that you will regret doing so, because you'll have happy patients and great outcomes, and you'll be a happy surgeon as a result. So that is my abbreviated talk. Sorry, we didn't get to go through all the cases, but I did want to kind of talk through kind of the strengths of endoscopy overall. Are there any questions?
Thanks, Peter. That's awesome. Yeah, and I know you got to get going here in a minute. So do any of the fellows have any questions we can ask Dr. Derman?
I will say that a lot of those cases that I had to kind of skip over, I did a recent Seattle Science Foundation talk. So if you look on the Seattle Science Foundation, those cases will be there if any of the fellows are interested in seeing those.
Just a quick question, if I can, honey, for Peter. Peter, great presentation, John Hurlburt, University of Arizona. What are the limitations? I get the sense that redos aren't a great way to shine on this procedure. Where do you draw the line?
Yeah, very good question. The main limitation is bone removal is slow with uniportal endoscopy. So in patients with severe bony canal stenosis, you can do it with the endoscope, but it's pretty slow. And you've got to decide at some point what's more morbid, substantially more anesthetic time or a slightly bigger incision, and you're doing this through a 18 millimeter tubular retractor. And for me, for patients with really bad bony stenosis, those are the ones that I'm still doing through a tube, a Metrics tube. Redos, you mentioned, it depends. So if it's a disc herniation at 4 or 5 and above, and you can get in there transforaminally, that's actually a great use for an endoscope. But I'm not a huge fan of repeating the same course with the endoscope. So if it's 5-1, somebody's had a previous interlaminar or traditional discectomy, and they need another one, then that's usually where I just use a tube. There are folks who do it, but it's just a risk benefit thing. And I don't think using an 18 millimeter tube makes that much of a difference. And if I get a durotomy, it's just easier to fix. Similar for things like, big facet cysts, there are folks that do it, but you just got to think about kind of pros, cons in your hands.
Thank you.
All right.
Awesome. Well, thank you so much, Peter. Just want to quickly shout out our next speaker, July 7th, Adam Cantor, who recently came out to the West Coast and now is at Hogue. And look forward to another great talk. Hope everybody has a great weekend. Peter, get to it. Thank you, brother.
All right. See you guys later.